So we're just going to have a look at hidden agendas. So randomised appraise patients versus agenda, patient's agenda, what's that wrong, versus your agenda. And I think this is, I mean, I get this a lot, and I'm sure, do you all get this? They come in with, or they actually, what they do is they ruin your morning because they're like this, you go through all your stuff and they go here. But I've got this problem, I've got a lump in my breast and you're going. But now I'm only run 25 minutes late because I've got everything done that I thought I was going to do, but they finally get the courage up to say what they've got and what's wrong with them. So it's just having a look at that. Now, which way around is this? Is it? I'm only one-handed. Sorry, I fell over last week running and broke my elbow. A bit of places. On my birthday, it was a lovely evening in Oceaniani on my birthday.
Press down from now on.
Okay, so that's it. So yeah, patients, Ren's already alluded to this. They bring concerns, ideas, expectations, feelings, emotions that they've got, and you can put that together. That's the patient's agenda. And sometimes they're open, but sometimes they're hidden. Anyone got any examples? Most of them have it.
Yeah, if it's out expansions, it's hidden.
Oh yes, definitely. Yeah, no, definitely. I mean, I've always used this one, but you know, when you speak about, you go through, as I say, you go through the whole consultation at the very end, they actually tell you what's really wrong. So it's just
women in vaginal dryness.
menopause and the erectile dysfunction, yeah. But also it might be that actually I'm really scared because my mother's just died of cancer. I'm really worried I've got it, and they don't tell you that until the very end. So it's just being, and I know this is all stuff you probably do. It's just really to remind, because I think it's something we get carried away with. So so patient might have a very good idea. You know, you've got the expert patient who comes in, having read everything on Google, on every website going, and they know more than you as far as they're concerned. They've worked it out, and then you have to kind of very cleverly unpick that. And then it's the patient who's coming up with all sorts of things, and it's looking at what are you really worried about? I've got a backache, and you know, or whatever. And you're saying, what is your darkest moment? What do you really think is, what's your fear? What do you think is going on? I'm getting headaches all the time at the moment. And I know I'm doing it, but we all do it, don't we? So we've got a symptom, we think the worst case, we catastrophize everything. So it's just picking up on that, because they'll feel silly. I feel silly. My grown-up head, I think I'm absolutely fine. It's no red flags, but in my, rational head, I'm thinking, oh, I get this every day. So you worry about it. They're afraid, and they're afraid, your diet's maybe spot on, but if you haven't uncovered what their real concerns are, then walk at them, they're going to come back, and that's your multiple visit patient. What are you hoping we can do? What's your patient's expectation? What can we do for you today? And above all, don't try and guess what the patient's thinking. So, sometimes now I will open my consultation with, and I do get half an hour. Sorry. I do get half an hour, although these multi-morbidity ones start off with 20. I was like, how can you make me do multi-morbidity consultation in 20 minutes? But now for half an hour. But I've had to fight for it. But half an hour is what you need, if not more. Probably need 45, to be honest, to do it well. But you start off with, what can I do for you today? I've got my agenda, I have my shopping list, but what are you wanting to get out of today? And that can sometimes really set the tone better. And I know it's really difficult when you've got 10-minute appointments to GPs, or 10 minutes or 15 minutes, to do something. But if you can get to know what they want, if you unblock that, patients are so much more amenable to listening to what you've got to ask them to do. It does work, and it is a bit of hard work. So the hidden agenda refers to their conscious or unconscious ideas, concerns, their fears, their expectations that underlie why they're there. I mean, I don't know about you, but I get patients coming already angry. You're not going to sort me out. What's the point? I'm just here because it's ticking your box. So, getting underneath that, and when I do get underneath that, then I can get to really making a difference to them. But until I get through that layer, I just can't get anywhere really with them. So the root of the problem, I think you took the slide out. Was it two? No, maybe it's wrong. How much time it takes. So it takes, the doctor listens for an average of 25 seconds. 18 seconds. And if you actually stopped and listened to the patient story, it would take them 2.5 minutes. That's average. It's quite powerful that, because I'm, you know, it's difficult, isn't it? To sit there and just, you know, you think sometimes they love the story, it does go on for 1.5 minutes, and you really do have to rein it in. But you know, it's just an interesting thought. So we're very used to machines. Our computers, we've got 2 screens. Sometimes it's not quite facing at the patient, and that's often patient's feedback. So it's just making sure that, you know, we're looking at the patient. I know you probably all do this, but it's just to remind me, because I can sometimes have it on the wrong screen before I know what I'm typing away. With my back to them, and that immediately creates a barrier. In specialist practice, focus on we kind of tend to put the biomedical aspects and not the psychosocial so much. And that can result in frustration for the patient, because actually you're not, as you said, we're not following what they want. And then it's when you've got that blocker, then you're never going to move forward, it's not going to come back. So it's just remembering that. So biomedical versus biosocial. So biomedical, it's all about the biological factors, not looking at the psychosocial and social influences, focuses on the physical processes, and it's good for, you know, it's pain or something simple. Each illness has a cause, kind of going through it methodically, but the patient plays a relatively passive role. Yes, doctor, yes, nurse. You know, we're not looking at everything that could be leading into that. So, and then you've got the biosocial. The social is you've got your little self here of biological factors, but out here you've got this is, I always say they come in with their suitcases of what they're bringing in the door. Could be had a massive row with their mum, or their daughter, teenage daughter's been really rude to them. They're coming in with their own agenda, their own stuff that's been going on. So they're walking in the door with all of this. What's going on? How's work? Their work's terrible. They're being bullied. Their housing's terrible. So that's what they're coming in with. Yours, in our simple minds, if you remember, I just got a diabetes and maybe a COPD review to do. Let's get that done. They're coming in going, got all of this. I don't want to deal with that right now, because I've got all of this to do. My suitcases are full of my stuff. I want to deal with those suitcases. I don't want to deal with you. And that is really, really hard. And it you know, and it often I have to, and it's hard because I'm going off box and I need to do everything. But I'm also thinking, actually, at this point, I have to abandon. I don't mind, I might get in trouble with the managers, but I have to tick that box. But actually, what I have done is I've signposted and sorted them out, and that patient will come back to see me, because I dealt with all that stuff or help them deal with that stuff. And it's just remembering, you know, yes, in the back of my mind, I think, have I ticked that box? Have I done that? But at the same time, I'm thinking, but actually what I did do was I referred them to social prescriber. I put them in with the physio. They actually felt heard. They went out smiling. And actually, they're more than happy to come and see me next week or have a phone call to pick up the bits I didn't get done today. So it's just trying to remember that, because it is hard, because there's so much pressure on us. Cough, cough, cough now, especially 2 weeks ago. Less than that. 10 days to go. A week to go.
Yeah.
Oh my God. So it's like, you know, get that done, get that done, get that done. And how many patients have been doubly called in? Because again, we're not, one arm's not talking to the other, and they're cross already with them coming in, they already came in last week. So, you know, you're dealing with all those things, and they've got precious time. Everyone, it takes time to come into the GP. Parking, cost of the bus fare. So we just need to you know, remember they're walking in with all of that as well as what we've got to do. So the biosocial module is looking at the biological, psychological and social factors. So that whole thing there, and looking at the collaborative approach. So it just means that that's the whole point of this project, is it's looking at the multiplicity of the whole patient. And looking at every aspect. I mean, when I did the talk last week, 2 weeks, 7th of March, when I did it last week, we had a lot of social prescribers on, and everybody in the room said, please tell the clinicians what we're doing and who we're about. And I didn't promise, so I will. So now she didn't send me a little slide. I asked her to send me a little slide, but they're there. Social prescribers are there. They often don't get a room, which is really frustrating. They don't get to see the patient face to face, but they are there and they are wanting to do a good job. What they struggle with, just the feedback, is getting in touch with us, depending which PCN they're in. So they sometimes want to refer back to us, or, you know, to be able to kind of chat to us or have that, you know, conversation about that patient, which might save them a hell of a lot of time and some visits. So it's just about how we use our social prescribers better. We had one health and wellbeing coach who came, same thing. They've got lots of ideas and they're there for us to use and to work with. And I think I want to do a whole work of getting them more presence and getting their faces to know more, because I think they are often the suitcases can be sorted out by them. And I think it's about making sure that we've got that in our heads every time. Actually, that suitcase there, I can definitely refer that to the social prescriber, and that suitcase there, actually, I'm going to do with the physio. So and they just feel heard and listened to, don't they, if we do that. But please remember, social prescribers, if you can find them a room, I don't know, no one, can't build a room especially for them. But I do think it'd be great to have them physically around, so they're part of the team more, because they're as important, in my view, as the medical model. And obviously physios have a room, and then health and wellbeing coaches, I think they're back too. So that whole team we need to big them up. We need to get them up and so much more present, don't we, involved in everything. So, and that's why I promised I'd say that. They said, please tell us what we do. So that they do, and they have a very important role, and they know everything. They will know what's in Lambeth, what's in Southwark, what's in Lewisham, for all the, the charities, the support groups, I know one in Sydney Gardens in Lewisham. They'll know where all they are, but we don't. I've got time to be Googling 50,000 charities, but they want to instantly know where to go. So I think it's really useful to make sure that you link in with them. If you don't know who they are, find out who they are. Sorry, I've gone through that. So health, disease and illness. Health is a state of complete physical, mental, social well-being. Disease is an abnormal pathological state, and illness refers to the feeling, how you feel, discomfort, tiredness, general tiredness the person might be feeling. So weak points. Patients routinely often bring more than one concern to the consultation. How many, all the surgeons have is a 10-minute consultation. We all know this for GPs. Then you've got to write it up. Let's go to 2.5 minutes to tell you the story. And then you've got like 7.5 minutes to examine, get the rest of it, get your stuff, what you want to get out of them, and then you've got to write it up, and that's 10 minutes. It's mad, totally mad. So it's about finding the time, and I still think we should fight for more time. I know it comes from the government, doesn't it, how many patients we should see a week, but I think it's a wrong equation. But yeah, so we need to go with the order that patient's coming in and say, what is your main concern you're walking in this day? I noticed that when I've looked at GPs, particular GP in my PCN, he said patient's agenda, and he's actually written down what their concern is. So, and then he can take it from that point. We don't need to assume that the first concern or symptom is mentioned for the plain one. As we know, it can be the handle on the door moment. And we mustn't interrupt too early. Very tempting, especially if someone goes off on a tangent. If they do go on a tangent, it's really back in. But it's helping that patient feel really, really heard, and just not looking at our screen, putting our hand on the table, and just looking at the patient their story makes a really big difference.
I don't know the ones I think to make it in terms of the point of contact with patients being the fundamental stuff in the hospital, how we can get them in. I feel like the first point of contact removes some of the barriers that face by people. Sorry.
No, absolutely. We thought about bringing these NCTs, didn't we? If you've got an NCT meeting, it really would be useful, especially with this project, to start off and find out the things, is to bring them into our entities. So you've got feedback from the social prescriber, the health and wellbeing coach, the physio. If you're talking about the patients and also the care navigator, a representative would be useful. And that's what they would like. They would like a place at the table. They have lots of ideas. And it's about, I know this is a small group and we're not talking to everybody, but I think we sometimes forget, and I'm guilty that actually there's lots of ideas that we're not grasping and using because we don't ask. So, I had 50 people in that room? I don't know how largely. 50 people in the room, they were full of life and they had lots of ideas. Blue sky thinking, we noted some down, and I think they've got a lot to say. And I do think it is about bringing them bringing them to the table. We're doing this project to hear what they've got to say. But try not to forget them, because they are useful. Maybe it's difficult because it's different type of teaching, but it'd be good to got everybody in the room, to talk. So primary care and the hidden agenda. So patients that offered kind of undifferentiated encounter patients conveyed distress with no physical symptoms can be found. It's basically just to look at what's going on, unpick, just got to unpick it when you see it with a patient. If it's really vague and they keep coming back, there's obviously something we're not answering. So it's looking at, making sure that we can do that. So reasons behind hidden agendas, they may not reassurance, they may need reassurance, they want to, so their friends just died of cervical cancer or breast cancer and they're panicking, they just need reassurance to be able to ask the questions they need to ask. They just need some sort of, us to say okay, or let's look at that. Problems with living, they've got so many problems in their lives, their physical health, it's not as important actually as their actual living conditions, and the need for a sick role. So people actually require certification of being ill, begin the consultation with a description of symptoms rather than actually demanding a certificate. So they may be worried about asking for that and go around that. It's basically they sometimes don't come to the point, and it's annoying because you've only got 10 minutes or you're lucky half an hour, but even half an hour, believe me, if you're doing all those conditions and trying to unpick all of that, it's not long enough time to bring it up. So how to uncover it? We need to decipher in order to prevent the patient's dissatisfaction. It's reading the body language, it's recognising cues. You kind of pick up when you're not hitting it, don't you? You can see the patient disengaging, they're not really listening to you. You haven't really, there's something else going on, they're not really happy. So it's, and I think you get better and better at it, and I think as I've taught this and learned, I think a lot more now when that patient sits in front of me before I start, and I actually get a lot more out of the consultation because I'm not just doing what I need to be doing. Patient is a human being. This is my big bugbear, having just been and sat there and somebody put this back stuff on without any analgesia or reassurance or concern, I felt like, oh my God, I'm human. Are you not going to recognise that, some people are so tired. She'd done 6 nights in a row. She was tired. All she wanted to do was get through the night. And she wasn't a horrible person, but she forgot, actually, this really hurts, and forgot to offer any extra reassurance. And I think that can happen when we're really tired. You've got 5 patients waiting. You've had a surgery going since 8 o'clock. You're running late because you've had 2 handle on door moments or receptionists coming in and interrupting you. It's really difficult sometimes to give every patient that, and we're human. But it's just remembering they're also human, and they'll go out and remember that one consultation. You won't remember it because you've had 10 for it and 5 after it, but they will go away and tell that story. And I was doing we were talking about child illness, we were working out a new way of teaching it, and we said, that first illness to a parent, if that nurse does it, we don't remember that we did it really badly and didn't look at the patient, but the parents, we didn't reassure them that they will go away and tell that story for years and years and years to come. So it's just remembering that, and also, would you like to be treated like that? Would you like your, to come out of the doctor's surgery being as frustrated as that? So it's just remembering those things. So just being empathetic and just really using your active listening skills and recognising the hidden agendas. It is difficult because it's a lot of pressure and a lot of I said we've got to try and stay positive because there is so much negativity around primary care. We're up against Facebook, we're up against Daily Mail, we're up against, I don't know what other newspapers are against us, but everyone seems to be against us. We've been like, let's clap for us all, but we never really aimed for it. Now we're like, oh, primary care can never get through. 50 the queue, GP does nothing, GP's lazy, nurses, and we're constantly battling against this view. It's soul destroying, but we've just got to somehow stay positive that we're doing a good job. And I have to watch myself because I sometimes get very caught up and think, oh, it's so depressing. But as long as I'm doing my best at the end of the day, and the patient's going that happy, then I'm doing my bit.
Just going back to the social prescribing, but also one of the things I also picked up is that I don't have that much experience with primary care, but just from what I've seen, is that in a lot of the surgeries we have very experienced healthcare assistants, very experienced healthcare assistants that know that have been in primary care for a long time. And they seem to have a lot of good rapport with patients because they do the bloods and the things that they do year after year with these patients. And I think that we really need to think differently on how we need to utilize that workforce. And I think that if you make one of the things we did was making one of them like the social time champion type of thing, and let use that stuff, because I understand the pressure of, I think the G, by the time a patient comes in front of the GP, I think that we need to think about what needs that it needs to be that complex, because there's a lot of other staff that can deal with a lot of these things. And because if I just put myself in the GP's place, we still doing all of that, with the range of staff in the practice, we can sort of bottleneck what goes to them and utilize the staff that's on ground. So I just think that with that social prescribing, we can bring that support, but we need to use the right people within the practice with that agenda.
No, absolutely. No, I mean, that's what I was saying. We need to train everybody up from the first person that patient meets walking in the front door to the next person, to the next person, the next person. Everybody needs, this is where you're saying like not picking up or not acting on a high blood pressure 20-25-year-old. That's where a GPA or an HCA is trained up to say, I can't do anything about that myself, but you know what I can do? I know what I need to do. I need to get you to come back with a week of readings and put you with the GP or the advanced practice nurse to do that. You know, so it's about training our staff up from absolutely everybody. This is the whole point of this project, is to get, and we're sad that not enough people have come. We wanted more people to be here today, not just people who've been on, because this is about how we're going to try and change our practice overall, all of us, to try and get this sorted out and get this better. So we're not being reactive, we're being proactive, and that is about having everybody on board to signpost and to unpick and to be confident. If they can't fix it, they know where to go to fix it. They know who to ask, and it's not difficult, and it's all about communication as well. But it's just we're just starting it, hopefully, and we can build. And as I say, we've got to keep positive. No, it's really difficult. Really difficult to be positive, but we kept to, you know. So there you go, 18 seconds. And so ideally 2.5 minutes. So let's try it. Everybody try it when they're next seeing a patient. Just see when you're desperate to interrupt, how long does it take you to want to interrupt? And then how long does it take them to get their story out? Let us know. Let's test this research. Let's see if it's wrong. So, you know, let the patient feel heard, and that's not just about, can I tell them a story? And they're talking away, you know, it's about telling you face on the patient. And it's really easy to be stuck in emails, isn't it? Because there's so much to do, and you know you've got to write your notes up, and you know you haven't got very long. But the problem is they're looking at you and they think you're not interested in what I'm saying. What's the point of speaking? So then they get cross, and then you've already got a barrier. Interest and respect for the patient. That's looking at them, preventing from making jumping the gun, reducing that, which will help reduce complaints and hopefully reassure and reduce anxiety. It does, you know, it's the simple, silly, minuscule things that can make a really big difference. And I think change your whole consultation. But please try it out and let me know. I'm going to make sure I time myself next time. See if I don't interrupt. So once you've, after the patient's finished speaking, checked you've got all the other, you know, what else? Is there anything else you want to say? You know, and also, have I heard you correctly? So I'm just, you know, you think you're going to go through this motivational interviewing. Let me just summarise back to you what I've heard. So if the patient continues resuming listening to the patient stops going, well, within reason, it's like 20 minutes down the line and, you know, they're not really, but we need to think about how we're going to somehow get them back to the point. Confront the patient by expression of disease. You look unhappy, so they're not, or something else is on your mind, and allow the patient to admit their anxieties. It takes time, and I think as we practice it more and more, it gets easier, doesn't it? It does become just a habit, you know, and as I say, you'll go out with a very happy patient, or happy, you know, in the sense that they'll feel heard. What's the script here? Just an example. It's an example. Doctor, hello, Mr. Jamal. Reception tells me you're here about your cold. Yes, that's right. I want to cover that in detail. However, I was wondering if you are hoping to cover any other concerns today. Yes, doctor, I want to mention my sore shoulder. I see your shoulder hurts. Anything else? My blood pressure is acting up. Okay, any other concerns? Well, I was a little concerned about my pressure in my chest. Might be from my heart and not only this cold. Oh, I can see that you might be a worry for you. We definitely need to discuss that. What else? I think that's everything. So as I understand, if you have a cold with some chest pain you've been worried about, your shoulder's been hurting too, and your blood pressure is a concern to both of us. In our time in office today, I would like to cover the most important items. I recommend we deal with your cold, chest pain, and the blood pressure today. I'm concerned about your shoulders too. Would you consider coming back? Yeah? How long will that take?
So the kind of evidence around this is the what else part of it. And it's also the idea that you don't then end up with your patient heading out of the room and going, oh, by the way, just while I'm here, it's a couple of things actually. And the other thing is that you don't sort of affront them or disengage from them because you're saying what else, instead of saying I can only deal with one problem. Now you're asking the patient to determine what's the most important. Now, from our perspective, it's probably going to be the chest pain in this situation. But what's making them feel the worst is their cold. And so they want antibiotics for their chest infection, whatever their agenda is. And so the argument is that if you get all of that out first by saying what else, you're then demonstrating that you are listening, that it's unreasonable for you to have to do all of that in one go. So you've heard what the patient says. However, what I suggest is, my opinion is these are the most important things. Let's get those dealt with because they overlap anyway. And then anything beyond that, we're going to need to bring you back. And so it's a bit of a finite kind of statement as well, because you're not saying, I'm not going to see you for your shoulder pain. What you're saying is we can't do all of that in one go without being affrontive to that patient and saying, what on earth do you think you're doing in the 18 different things? And the other problem we have at the moment, of course, is that patients are under the impression that it's hard to get an appointment. Now, in some cases, there's an awful lot of patients who phone up that morning and they get seen, they get an appointment, they get a phone call, they get something. But because of the pressures of social media saying it's really hard, if they come up against any barrier at all, they immediately kind of say, oh, I've waited ages. Well, realistically, you haven't actually. And realistically, you don't need to be seen today. This is something that maybe you've left to the last minute. You've left it until you're on annual leave and now you've got an appointment. So from a behavioural point of view, if you look at the human behaviour around it, not sort of pushing back and saying we can only do with one thing, but actually saying what else? Okay, let's deal with this and this today because that's the most important stuff.
With the big for your shoulder.
But if they turn around then and say, but I need to deal with all of this, then you can say reasonably in the time we have, we're not going to be able to do that. So you're saying that we'll cover the important things, but the other stuff you're going to have to come back to. Or we'll refer you somewhere else or something like that. Yeah?
Any questions before we get on to the last section? I know it's probably what you do every day, but it was just a reminder. So don't feel it wasn't meant to be patronising. It wasn't going to be, say, assuming you don't do it. It's just really it's just a little reminder. That's all.
Okay, so this is just, again, I suppose a revision. Some of you would have done a lot around motivational interviewing, some of you won't, some of you have some concepts of it, some of you won't. And it is still recommended as a sort of evidence-based approach to behaviour change. So one of the biggest things that we're up against is getting patients to change the way that they think, change the way that they manage things, help them to give stuff up or take stuff up if we're talking about sort of exercise and things like that. And if you look at motivational interviewing in general, it's enormous and there's loads of different models and there's loads of grey areas about how to do it best and what actually takes more time and what's effective and what isn't. And so sometimes you can start looking at it and go, well, that might be a good idea, but I haven't got time even to read about it, let alone undertake it. So there are just some sort of relatively simple things that you can kind of incorporate into your consultations, particularly in relation to behaviour change in your long-term condition patients. So this isn't saying you change your consultation styles. What this is saying is that for those patients who've got comorbid conditions, whereby behaviour change is probably going to be more effective than some of the pharmaceutical stuff that we can give them, then how do we go about that without them getting all ragey and all that sort of stuff? It's very difficult to tell people to do things that they're already aware of. So there's no point telling people that smoking's bad for them. They already know that. So they just feel, you know, kind of like, okay, well, this is a waste of time. And similarly, it can be quite difficult telling patients that they're overweight and things like that, because, you know, it feels offensive to a lot of patients, and they might feel embarrassed, and they probably already know that they want to lose a bit of weight, and they will have been told before. So how do we kind of go around that to get them to create realistic goals that are made by them as opposed to made by us? That getting louder.
Yeah.
It is. Or about someone like. I think it's the end one. Is
Oh,
it?
no, it's a fan.
Yeah, it's very.
Can we turn it off?
Yeah. Is it cold? Because lots of people have coats on.
Yeah.
Okay, sorry, it's just I was kind of thinking, well, surely we're going to blow up something. She's getting anxious. So what do we mean by this? So it's basically a guiding style of conversation. So you're in control of the conversation, but you manage it in a way that allows the other person to feel as involved, if that makes sense. You're steering it and you're guiding it. And the idea is to sort of empower people in a way to kind of draw out what's important to them in terms of what they want to change. And this comes back to what I said earlier about what we want from a consultation and what your patient needs from a consultation to go away and feel satisfied. And how do we bring those two things together? So you need to be kind of naturally curious in a way as to what their thoughts are, what their feelings are. If you look at the spirit of motivational interviewing, what it talks about is collaborations. It talks about evocations, and it talks about honouring sort of autonomy. You might have a patient who doesn't want to give up smoking. They love it. It's the only thing that they've got. They gave up drinking, they gave up sugar, they've lost weight. Smoking's their last thing. I'm going to hold on to that. You are wasting your time to focus your consultation on their smoking cessation if they've no interest, because it won't happen. People will only change when they are ready to make that change. So you can suggest it by all means. But if you come up against it, no, I'm not going to do that. Let it go. Ask every following appointment by all means, because people change their mind. But there's no point trying to force something or force a change in someone. It doesn't work. If you look at the more authoritative sort of paternalistic style, which is what if you trained decades ago, it was a little bit more like that. Doctor is always right sort of approach. We tend to have more confrontation. And that's where the patient will they'll either get really annoyed with you or say, well, you're not listening to me, and those sort of things. And then we kind of have the authority to say, well, I'm going to change your medication today. No kind of conversation about whether that patient wants to change the medication. We've seen it in the past with mass switches of inhalers. Yes, so when we decided, what was the purple one? Serotype.
Oh my God.
Because it was so expensive, and it was just a mass switch, wasn't there? People just went nuts because they were like, oh my Lord, where's my purple inhaler gone? It doesn't really work. So if you look at change behaviour and you look at change management, then people only voluntarily change when they're actually interested or concerned about the need for change. So if you've got a patient who has no interest in losing weight, regardless of the fact they're morbidly obese, they won't lose weight. Doesn't matter what you do, give them all a stat and send them to dietitian. If their interest isn't there, it won't happen. Now, this isn't to be like kind of fatalistic and be a bit kind of like, oh no, how terrible, what's the point, why am I bothering? It's more to think about, okay, what part can I focus on with this patient that they might be willing to look at? With patients in long-term conditions, we quite often say, right, you need to stop smoking, you need to lose weight, you need to take this vitamin supplement, probably need to start moving a little bit more. And all of a sudden you've given them 5 big lifestyle changes in one go, which is impossible. So far better is to say, okay, out of these things that we know can help you, which one of those do you think you can make a start with? Which one of those do you think you'll be the most successful with? And see what they come up with. Because it's those questions that is going to show where they're interested in the most in terms of what they can change. Okay. It also sounds a little bit more achievable than trying to change their whole lifestyle. Because not only are you changing your lifestyle, you are changing who the people around you know you as. So if you are a smoker and you give up smoking, but your friendship group still smokes or vapes or whatever, you become unfamiliar to them. And so they won't be encouraging you, they'll be probably encouraging you to relapse in a way. So otherwise you're putting a subconscious pressure on them to do the same behaviour. You see it with patients who have very sort of social lives in terms of restaurants and food and things like that. With obesity, and they go for gastric banding or they go for sleeve surgery and things like that, they can become quite depressed because that part of their life that was very social around food and cooking and going to restaurants and things has now disappeared. So the goal was achieved, they lost weight, but what did they lose with it? And that's why people either relapse or they stop the change they were undertaking, because they go back to what's familiar, they go back to what people are comfortable with them being, even if it's a negativity in terms of health. They must actually organise a plan of action and make a commitment, and a verbal commitment is far better than them just nodding and say, yes, no, you're right, doctor, I should do that. So how are they going to do that? How are they going to make that change? When we look at probability of behaviour change then, and I've simplified this quite a lot, but from the low likelihood of someone changing to a high probability of them actually being able to change, what we want to think about is getting them to make that verbal commitment. And the only way they can do that is if they talk personally about why it's important for them to change. If this is you doing this bit, they're not going to get to this bit. Because if you're saying it's really important that you stop smoking now, we can see there's a problem with your airways, it's a problem with your breathing, so we really think that we need to change that. The question should be, you know that I'm going to suggest not smoking, why do you think that would be an important thing for you to do at this stage? To get them to answer that question. Because I've got a problem with my lungs and I know that's not very good. Okay, yeah, I agree with you. Yeah, so trying to get them to take the onus, take the responsibility. So I only put this in because one, I like the dinosaurs, they look so happy. But it's not the strongest of species that survives, it's all the most intelligent, but the one most responsive to change. And that's one of the difficulties that we have, is that we like routine. Most of us do exactly the same thing every morning, give or take, in terms of the order that we do stuff in, whether it's that you shower first or you have your coffee first, whether you do teeth before or after breakfast or both. And if you have to do it the other way around, it can make you feel uncomfortable. Most people will, if they get the same bus every single day, will sit roughly in the same seat, stand on the same place on the train platform. If we had another day tomorrow, you probably all sit in the same seats that you're in now. It's just routine. We thrive on it as humans. We learn from teeny tiny about routine from the moment we're kind of birthed. We are put into a routine, albeit somebody else's and your parents. But it's routine, is that you sleep at this time, you eat at this time, go to school at this time, you start work at this time, blah, blah, blah. So we like routine, and that's what makes it so hard to change. So the first thing that we need to do, and appreciate again, this research is old, but it's stood the test of time, which is why it's 1986. It has been sort of changed and updated since then, but these were the original guys that put it together. And they propose that readiness for change is really what you need to be establishing if you're trying to help or motivationally get someone to kind of change the way of thinking. One of the biggest issues that we'll have, one of the most interesting things you have, particularly with long-term conditions, is ambivalence. So you'll have a group of patients who know exactly what needs to change. They know what they need to do, but there's a level of ambivalence, and that's what we refer to as a conflicted state of mind. And the reason they're conflicted is they've got opposing attitudes or feelings whereby they're stuck wanting to change, but not wanting to change. They're trying to determine the pros and cons of both as to which is going to be more worthwhile their effort. An example of this then could be where you've got situations where there's a conflict between gaining an immediate reward, okay, and longer term adverse consequences. So that immediate reward could be that dopamine that you get from nicotine, from caffeine, from sugar, from whatever you get it from. So you may have a patient who has serious health problems as a result of heavy drinking, for example, or drinking a lot of alcohol. They show genuine concern about the impact of alcohol on their health. So they're engaged in that respect. They know that it's not a great idea. They know that their ill health is probably secondary to this as a causative factor. But in spite of that advice and in spite of that knowledge, they carry on drinking at harmful levels. And that embodies that phenomena of knowing that what you're doing is detrimental to your health. And we are all guilty of it. Every single human has a crutch of some sort, something we turn to when things aren't great. Some people it's alcohol, some people it's smoking or vaping, some people it's food, some people it's exercise. They can have shin splints and still try and run. How's your elbow? Yeah, so they'll still undertake something. So even though it could look like a healthy behaviour, anything that is done excessively anything that you cannot get through your day without doing isn't necessarily healthy, even though it might appear so if it's related to exercise and things like that. So where's the ambivalence and where do we stop with those kind of things? So there's three critical components then to get past that. Yeah, it was just the noise from the aircon, if that's okay. So there's three sort of components we want to look at. We want to look at the importance of change, the confidence to change, and whether or not the change is an immediate priority. And this comes under three things. For the patient, are they willing? Are they able? And are they ready? Yes. If you're speaking to a patient and they're not willing, stop right there. Don't waste your time. If it's that they're not able, then you may want to explore with them why they feel that they're not able, because that's actually where you can step in and give them very good advice. Is it that they're not ready? In which case, I know I want to stop smoking. I absolutely want to, but right now things are really stressful. I'm pretty sure I'm going to fail. I'd like to just maybe come back to it. That's fine. So you're willing, you're able, but you're not ready. So where is your patient sitting in those parameters if you're going to try and get them to undertake a change? And we can see how this is put into practice in terms of evidence of something like a very brief advice for your smoking patients. You can see here you're assessing those three things. What's the confidence? What's the readiness? It may be you ask them and they go, I know I want to give up. It might be that they've got the ability to give up and no, I can. I've given up before. I know I can do it, but I'm just not ready. So I don't need to act on that right now. So we can see how that sort of follows already those principles in terms of giving up and those sort of things. So it's not just for the ambivalent. It can be really helpful when you're examining the situation with your patients. And what we're trying to assess is confidence, desire, and importance. You may have that your patient's confidence is really low. They don't think they're going to be able to do it. And they're so frightened of relapse that they're actually just not going to do it. They're not going to have a go because their confidence is so poor. It may be that the desire is low. So actually they're not really sure they actually want to, in which case they're not going to make the effort. Or it may be that the importance is low. Right now, with everything else going on in my life, I'm not able to do this. And with the importance, that's where you've got that helpful moment of if you want them to change 5 things, lose weight, stop smoking, reduce your alcohol, blah, 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 then you can say to them, okay, how do we order these in importance to you? Because it doesn't matter the importance to you as clinicians. It's what's important to them. So you might be thinking the most important thing here is I've got to get them to get some weight off because they're HbA1c. But they might be thinking, I have got to stop smoking. And that's what their most important thing is. And you must go with what their importance is and not ours. Otherwise it won't work because you've got to do it in the right order. Motivation is a fire from within. So if someone else tries to light that fire under you, chances are it will burn very, very briefly. So that's why the importance and motivation needs to come from that individual. What matters to me? What do I need to do about my life in terms of improving things? And what am I able to actually do? So this looks a little bit kind of, oh God, what's going on here? But it is just an algorithm. So it's the trans-theoretical model of stages of change. What it talks about is how pre-contemplation, I can stop shouting now.
Oh, yeah.
Pre-contemplation is the increase, thank you very much, the increase of awareness, okay? So at this point, as if from a clinical point of view, what we're saying is, are you aware that this is possibly having a bit of a negative effect? So are you aware that your diet as it is not great for your diabetes? Are you aware that your continued smoking is going to be problematic for your chest? Now we know what you've got, blah, 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 with your long-term conditions. Contemplation then is you then exploring with them their level of motivation. So what's the importance to them? What's the desire? What's their understanding of their possible ability to change? And this might be as far as you get in that consultation, because you might realise there's no desire, there's no importance, and there's no willingness. So don't waste your time with the rest of it. It's not going to change. If, however, they go, yeah, you know what, I think I could do this. I think it's time. What we need is the preparation. And this is the negotiation of a plan. Okay, well, how do you think you're going to do it? And you need the patient to verbalise how they're going to do it. This can be a discussion, because what you can talk about is not only how are you going to do it, but what are you going to put in place when you're vulnerable. So if you're going to undertake the cessation attempt of smoking, when do you think you're most vulnerable to relapse? Or if you tried stopping smoking before and you managed for 3 months, what was the stressor event? What happened that you relapsed? Because this is the preparation. What am I going to do if things go wrong? Okay. Action could be them undertaking, could be you doing a prescription for nicotine, could be giving them the NHS smoke-free number, depending on what that is. You've got two sort of things that might happen. It may be that you've got maintenance, so they're doing really well. This would be your counselling, your support, your follow-up, something like that. And it may be that they terminate. So they can stop making that change now because they've done it, it's perfect. Most of the time, because of the nature of the human mind, we have relapses. So for every 9 people who attempt to smoking cessation, only 1 will actually stay off cigarettes. So you're up against it anyway, which is why it's got to be the patient that does it and not you. If they relapse, we just need to see whereabouts they are. So do we need to go back to the contemplation? So actually, has your importance changed? Has your ability, has your confidence changed? Or is it just that there was a stressor event and actually you're going to go straight back to where you were before and you're going to stop again from tomorrow? So where are they? Because if you force a continued change when it's not happening, it's not working, all that'll happen is their confidence will go even lower for the next change that they try to make. So if we break that down a little bit more then, the pre-contemplation, they're not ready at that point. You're just identifying to them that this is something that they probably want to consider. You can at that point provide harm reduction strategies. So if they're not going to stop smoking, you might want to say, look, most people smoke throughout the day, cigarettes that they're really craving, that they need, and then cigarettes that are just habitual, that they're just used to doing. Do you think there's a possibility that you could look at the ones that you're just doing out of habit? So you're waiting for the bus, so you think I might as well have a cigarette because I'm waiting. Didn't need that one, you weren't craving it because if the bus had turned up, you would have got on. So could you try and get rid of that one, for example? Start to reduce the harm, reduce the amount that you're drinking, smoking, whatever. Your contemplation then, exploring the importance, identifying their reasons, getting them to verbalise their reasons to change, clear goal setting, as I said, and then that relapse, that learning. A relapse isn't a failure. And that's one thing that a lot of people in terms of undertaking any level of change are fearful of. They're fearful of failing. And so having that conversation up at the pre-contemplation, or if they're saying, I don't feel very confident, you can talk about, look, lots of people try and undertake change and lots of people don't manage to do it the first time or the second time. Doesn't mean you failed, just means that we go back to the beginning and we try again. Simple as. But they'll be embarrassed to come in and say that they failed. So that's the other thing sometimes. They don't want to tell you because they feel that you're invested in it. There is a degree of mismatch quite often between ourselves and our patients, and that's mainly because our viewpoint tends to start up here. We want action. We want you to stop smoking. That's what we need you to do. We want you to lose weight. We want your HbA1c to get better. Partly because of cough, and partly because we care about it. I'm hoping the latter more so. But the problem is if we start them off up here, we haven't allowed them to go through these 3 phases, and this can take 6 to 9 months for some patients, particularly if the behaviour asking them to change is lifelong. If they're in the 60s and they've smoked since the age of 12, you've got quite a lot of contemplation to get through before they're ready. So, does it really work? Yes, it does. So there's been plenty of sort of evidence and studies. There's been meta-analysis, and it shows that motivation interviewing is equivalent to, and in some cases better than, cognitive behavioural therapy and or pharmacotherapy. So it does work. We just have to know how to utilise it and how to go about it and what language to use. And as we go through the next sort of 2 clinical days, which are online, we will talk about this as we thread it through your COPDs, through your diabetes and that sort of stuff, how you have those conversations. We know that it works as well in other health conditions, things like smoking cessation, reducing sexual risk behaviours. There was a whole study about that, improving adherence to treatment and medication, and diabetes it's very effective in as well. So how do you apply it? It's all very well and good saying, I know it works, I know it's a good idea, but what do I actually need to do? So the practical approach to motivational interviewing then is 2 phases. One is building motivation to change, and the second one is trying to get them to strengthen that commitment to change. And in phase 1, so the building motivation, they use 4 sort of early methods. So the OARS acronym, which is your open-ended questions, affirmations, reflections, and then summaries. And it looks a little bit like this. So open-ended questions means that you want the patient to do most of the talking. Okay, so for example, I understand you have some concerns about your drinking. Can you tell me about them? As opposed to saying, are you concerned about your drinking? Because I might go, yeah. And then you're like, okay, now we'll ask the next question. So what you want is to get them talking. Most people feel uncomfortable still in a silence. Patients definitely do. Clinicians are a little bit better at it, especially if you've got end of life or palliative care experience. And so the key here is to shut up as a clinician and allow them to really speak. If they go, well, you know, it's bad for your liver, isn't it? Just hold that for a second, because they will try and fill the silence. They won't like it. Whereas if you can hold that, they'll go, and you know, I don't know, maybe I row with my partner more when I'm drinking. So now you're getting more information out of them. If you rush in on the first reason they give you, then you haven't got as many reasons to affirm and to sort of strengthen when you come to phase 2. So you want to get as much information about what's concerning them as possible, and holding a silence sometimes does that. It'll only take 30 seconds before they speak or so. The affirmations then are kind of things like compliments in a way. You want it I say this all the time, don't I? But from a kid, we are told the best thing to get is a pat on the head, a well done, a good for you. So if we're not doing that with patients, then unfortunately we're not kind of building that rapport or validating them, because we all want a pat on the head. We don't want to be told off. And so I appreciate that it took a lot of courage for you today to discuss your drinking or something along those lines. You appear to be quite resourceful given how you've coped with this over the last however many years. Thank you for listening. Thank you for speaking to me. I appreciate it's not easy. So all of those kind of things are sort of language that you can use that validates and makes your patient feel that actually they're not a bad person for doing what it is they're doing. Yeah. For your reflections then, the reflections involve rephrasing a statement. Okay, so you're going to rephrase stuff. So you're basically giving it back to them. And what you're saying is, so what I'm hearing is you enjoy the effects of alcohol in terms of it helps you unwind, but you're beginning to worry about your health, your liver, your relationships, whatever it was that came up when you were asking them what they were concerned about. So you want to be reflecting that back. One, to make sure you've understood it, but two, because phase 2 of motivational interviewing requires you to understand that level of contemplation, where they're going to go with it. Summarization then, if it's okay with you, let me just check that I understand everything you say. And then, you know, at the end of that, just saying, how am I doing? Have I got that right? Am I on the right path here? Allows them to sort of say, well, no, actually, I didn't say anything about my partner, or because sometimes we miss bits and we miss here and that sort of thing. When you get to phase 2, then phase 2 is the goal setting, the negotiating, change, plan of action, those sort of things. And this is your change talk, but it's the simplest and most direct way. So you want to think about targeted questions. You want to think about roughly about 4 categories here. So you've got disadvantages of the status quo, advantages of change, optimism for change, and then intention to change. So it's coming back again to that desire, that willingness, that ability. Change talk then, disadvantages of the status quo is things that will elicit it. So what worries you about your blood pressure? What difficulties have resulted from your drinking? So not me saying your blood pressure is too high, not me saying it looks like you're drinking too much, that's bad for you, and not me saying you're overweight, you need to lose weight, or you're underweight, we need to get you to dietitian. So actually what you're getting is for the patient to elicit what they're worried about, which is change talk. This is what we know are more likely to result in somebody undertaking an attempt to change. Advantages then, how would you like your health to be? How would you like it to look in the next 5 years? What are the advantages of reducing your drinking? What would be different in your life if you were able to lose weight? So what you're trying to get them to do is envisage the positivity that that change might bring, not just today, not just next week, but in the next 5 years or so. Where do you see yourself? Where do you want to be? If they're already there overweight with bilateral knee pain, their answer might be, well, I don't want to be in pain. I don't want this pain to get worse. I don't have to have knee replacements or things like that. If I lose weight, at least I won't have to wake up feeling guilty every morning that I'm not taking care of myself. So it may be that there is a low confidence around self-perception, self-belief, and those sort of things. And that kind of question can elicit that. This is going to identify to you whereabouts possibly their confidence is. and certainly where the desire is. Optimism versus intention, your optimism for change. When have you made a significant change in your life before and how did you do it? So get them to try and think back to when they were actually able to make a change and they did actually undertake that change and were successful, demonstrates to them neurological sort of pathway point of view that they are able to do this. Again, you're trying to improve confidence. Intention to change, again, what do you want your life to be? Forget for a moment how you would get there. But if you could change, if you feel like you could change anything to get there, what do you think would be the best way of doing it if you were able? Again, with this, you're looking at ability or self-perceived ability. Now, at this point, you might be thinking, my God, I've not got time for this. I haven't even touched on their FEV1 or their medication review. So you can do quick methods of change talk, which can be helpful if you're in those smaller appointments as opposed to your sort of longer length ones. And the sort of things that you can ask is if you can think on a scale from 0 to 10 how important it is for you to lose weight or whatever, stop drinking, smoking, whatever it is. On this scale, 0 is not important at all and 10 is extremely important. Where would you be on this scale? If they were to then say, well, I don't know, maybe a 6, what our response to them is, why are you at a 6 and not a 0, for example? So why do you think you've got a level of importance to lose weight? Gets them to start talking about why they actually want to change their weight again. What would it take to get you to a higher number? And this bit here is looking at to what they think might be causing the problem that they're not that important losing weight. It also gives you an in to say, okay, well, what can we do potentially, do you think, to get you to a higher number? I think I'd benefit from a dietitian. I saw one before. I think it would be quite good if I got a gym pass or whatever it might be. Yeah. The other thing that you can do, which is helpful, is to assess their confidence in their ability to change. So it's exactly the same thing with the scales. 0 to 10 of how confident you are that you can cut back the amount that you are drinking or whatever, weight or smoking. On this scale, 0 is not confident at all, 10 is extremely confident. Where would you be on this scale? And again, why are you not at 0? So you've got some confidence. What do we need to do, or what would it take to get you to a higher number where you're more confident? I think it would be helpful if I had, nicotine patches. Okay, well, now we know that there's a way that we might be able to improve your confidence and as such increase your ability to actually undertake that change. You will meet resistance, of course. So, the key, and I won't spend too much time on this because I absolutely know that you already know this, but, is to build empathy, is to get understanding. Not condoning problematic behaviour, but just pulling back when someone is no desire whatsoever. And you can say to them, okay, I can see that it doesn't feel to me that this is that important to you. Is it that it's not important to you at all? Or is it just not important at this time because you've got too much else going on? And then see whereabouts they take you with that in terms of their response. And sometimes they push back because they're embarrassed. So the key is to roll with it. Pick your battles. Some patients, as you know, you're fighting a losing battle most of the time. A lot of resistance is interrupting, so patients interrupting you, arguing, discounting your level of expertise. What would you know about it? Yeah, you're just a nurse, you're not a doctor. Or what would you know about it, doctor? You're overweight yourself, or anything like that. Those kind of things where you think, well, that was rude, but okay. And what they're trying to do is they're trying to reduce the pressure on them to undertake what they feel is going to be a really hard task. So just interpret the responses. It may be that you go back to that pre-contemplation phase and say, okay, see, it feels to me that you're ready for this chat today, and that's absolutely fine. What we'll do is the next time we see each other, maybe we'll revisit it then. So what you're saying is it's not important. What you're not saying is that it's not important. What you're saying is, I get that you don't want to talk about this right now. Doesn't mean it's not important. Doesn't mean we'll come back to it. And that also means that they will get used to being asked every available opportunity about smoking, about those detrimental things that we know about. Yeah.
Yeah. And they not, encourage their people to visit because they're over with themselves.
Of course they can, but what you might have is patients pushing back and sort of saying, it's a bit like seeing a smoking nurse, and then that nurse comes in stinking the cigarettes and telling you to stop smoking, and it's that kind of thing. So it's not that you can't, it's that how you word it in a way.
If you feel guilty yourself and you don't have the courage to say
Yeah,
it,
yeah.
will you be criticized for not saying
Some
something?
patients will criticise you and some won't, but you know, again, what you can do is think about how you change that language. So you don't have to say to the patient, you need to lose weight. You can say, okay, in regards to your diabetes, we can see that your HbA1c is exactly where we want it to be. What do you think you could change, or what do you think needs to change to help this come down a bit? That's where they go with it, because they might say, well, to be honest, I ate a few too many sweets, whatever. So you say, okay, so your diet, possibly your weight, those kind of things. That's them telling you, not telling them. Do you see what I mean? So what you want to get them to do is tell you what the problem is. And they know what the problem is. Then it's less didactic as well. So anybody done their colours before in terms of their personality? You will have, if you've ever been with me, you will have done. So have a quick look at those. You will cross over in these. You will find parts of yourself in all of these. But what colour would you say you are predominantly?
Red.
Red? Anyone else?
Green.
Huh?
Green.
Green? Caring, encouraging, sharing, patient, you relax. Yes?
All four.
All four. Everyone will have something of all four. But which one are you more so? If you had to choose one way of being, or if you had to choose what you feel your instinct is to be?
Green.
Green? Yellow? Okay. So all positive kind of things, aren't they? These are all things we can work with. These are nice things. Green, caring, encouraging. Who said yellow? Yellow, yellow. So social, quite enthusiastic. Yes. Okay. What if I was to tell you, this is how other people see you? Oh no. Now, it's not to say that that's exactly how it is, but the interesting thing is, you know, you might look at yourself being a joyful yellow, and we like this because we go, well, let's look at our personalities, and you think, oh, nice, I'm dynamic, I'm social. Someone that you work with is thinking, oh God, every morning. She's like, hi, morning, excitable. Are you listening to your work? I'm so excited. Yeah. So with green, similarly with green, you think you're caring, you're encouraging, you're quiet, quite relaxed, quite nice. Patients come in and the patient's thinking, Jesus Christ, they are stressful. Yeah, slow to act. Why do you keep asking me what I need to do? Just tell me, yeah? So if you've got a patient who's a fiery red, for example, are you going to be the best person as a mindful green to deal with that patient? Because if they're perceiving you as plodding, slow to act, when there's someone who is driving, wants to get done, let's go, let's move, you're 2 minutes late, what's going on? Why is it taking so long? And you can start to see the difference in personalities. Now, that's not to say that if you're a green, you can't see a red patient. What it's to say is that if you are one of these other ones, you need to think about how your personality, your approach to conversation might not be the right way for that individual. And it may be that the barriers that you're hitting is just because your personalities don't match. And it's not something you can say, oh, I've had training, I can deal with it. It doesn't work that way. Human behaviour doesn't work that way. So when I worked at a practice years ago, and was myself and another nurse, and she was, my God, she was joyful yellow. Everything was sunshine, everyone got smiles, everything was perfect. And some patients hated that. And I would say I'm probably more, maybe a blue, but I'm not sure. I don't know. But I'm certainly not a joyful yellow most of the time, to be fair. I can be jaunty, but not too much. And a lot of patients loved that for her, but a lot of patients couldn't stand it. Equally, a lot of patients didn't like me because I was like, right, let's get this done. This is the diagnosis, blah, blah, blah. Whereas what they wanted was a hug. And I was like, that's not going to happen. Okay. So we became known as basically the nice nurse and the horrible nurse. I was the horrible nurse and she was the nice nurse. Because she'd go down to the waiting room and chat for ages with everyone. And I'd be like, no, you see? But you can see how perhaps, just perhaps, you're not the right person for that patient or vice versa. It's also why you'll get patients saying, oh, I don't want to see him. I saw him last time, I don't want to see him. Not because you weren't a nice person, it's because your approach didn't marry up with what they wanted. You see? Which is tricky. Obviously, this is just an example. The interesting thing is it does change your behaviour. So people will behave in a different way. You get into a lift, everybody's end point, end goal of getting into a lift is to go to another floor, whether you're going up, whether you're going down. Yeah, but you could say, and again, this is hypothetical, so don't get offended. You could say that if you're a green, you're probably going to hold the door open for someone if you see them running. Yes, red is probably like, I'm going to say it and get the next one. I've got somewhere to do. Press, 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 press. Yes, yellow. Bet you chat with someone in a lift, wouldn't you? Look, the heads, it's like, yeah, maybe, yeah. Oh, where are you going? What floor are you going to? Yes, those kind of things. So even though the goal is the same and the end of the journey needs to be the same, how you get there relies very much on who you are as a person. And that's traits that we've had from our upbringing, our experiences, our development, our traumas, you know, grieving, loss, all of those kind of things shape who we are and how we respond to things. And it's the same for patients. So sometimes having those consultations and just thinking, oh, why isn't this working? Why is this patient not getting it? Maybe that they're not getting you, and that's why things are kind of gone awry. So we need to look deeper. So all behaviour serves a purpose. Everybody's got an agenda. Everybody has got where they want to get to. I want you to enjoy this and take something from this. By now, you're probably thinking, God, will she ever end? Yes, so we can go home in the nice weather, possibly avoid the rush hour starts now, doesn't it, really, in London? But everything has a purpose. Your patients come in, as we said, with an agenda, and you have one as well. The key is to marry them up. Also understanding that most behaviour has a reason. So when you've got patients who are pushing back, who are not listening, those sort of things, or patients who are very tearful or those sort of things as well, there'll always be an underlying something or other. And it's not always what the obvious thing is. So sometimes using different terminology, using different questions, I can see that you're hurting. What hurts? I've got constant pain in my joints. Okay, what else hurts? And see where they go with it. Because it might give you information that you wouldn't otherwise get using your traditional medical model or those sort of things. So the quick fix, this is what patients want. Yes, I want the quick fix. We want the quick fix. You're the expert. Why can't you tell me? You're the doctor. You tell me what to do. I'm not the expert on you. And that's the key. So it's a case of saying to the patient, look, I can give you an idea of what the evidence shows us, and I can tell you what other people have done in your situation, and I can tell you how other people have responded to the certain drugs that we've got for what you've got. But when it comes down to it, you know best as to whether you're going to remember to take them every morning. You know best as to whether or not you're going to be able to tolerate any side effects that you might or might not get. So instead of patients going home and having boxes and boxes and boxes of medicines in their kitchen cupboard that they've never touched but they continuously get on repeat, you're able to sort of say, look, there's no point in you doing that. I'm not going to judge you. If you tell me not to take your hypertension medication, all I can do is say, look, the evidence says that you're likely to come to less harm if you take the tablet. If it's the side effects, there's reams of medications we could try instead. So it's about being a little bit more kind of flexible to keep that person on side, especially if they've got a red personality. You're the only one who can decide what is best for you, and that goes for all of us, doesn't it? We all know ourselves the most. So a working example then, say you've got a male patient, 52 years old, drinks heavily, expresses the desire to reduce drinking but carries on anyway. Ambivalence. Easy to conclude that they lack motivation or the judgment's impaired or that they just don't understand, but that means that you might automatically drop into that paternalistic sort of attitude, not attitude's the wrong word, but that sort of style where you list the things that are going to be problematic if he continues that behaviour. In subsequent consultations, strategies don't work. It's easy to give up hope and just go, oh, we've asked him every single time. He's going to be a drinker for life. He's not going to stop. What can you do? Sort of thing. So you kind of give up. In motivational interviewing, the opposite approach is taken. And what we're looking at is the motivation that patient has. Is it important? Do you have the ability? Do you have the desire? Where's your confidence? Yeah, instead of just saying, you really shouldn't be doing this. Using the spirit then to avoid that authoritarian stance, which can be quite difficult when you're trying to, manage the consultation and get things through quickly, especially in long-term conditions, comorbidities, you've got quite a lot to do. Eliciting the reasons of change from the patient. So instead of advising them why we think they should stop drinking, saying to them, I think it's important for you to stop drinking, because we're making it about their behaviour, their thoughts, what their level of importance is to them. Lack of motivation might be there in unresolved ambivalence, and then you can go back to that pre-contemplation stage. How far can I get them through that stages of change before I need to stop and pull back and see where we can go with it. Or if they've relapsed, how far back do I need to go with this individual? And I know it sounds like it takes a long time, but it really doesn't. It really doesn't, not when you get used to it. If you work to resolve the ambivalence, then what you're able to do is connect things that the patient does care about. So once you know where they like put that importance, you can refer back to that and say, okay, I know that we've talked about your drinking before. The last time we met, you said you were quite concerned about your relationship with your wife because you felt that when you drank a little bit too much, you tended to have more arguments. How's things going with that? Now we're making it about you because that's what you told me. I'm not telling you you're going to row with your wife. You've already told me that that's what happens. So I'm reminding you of why you told me it was important. Do you see the difference? So bringing it to an end, it needs to be a positive end because you want them to come back. You don't want them to go, God, that was a telling off. Don't need to do that again. And so I really appreciate that you were willing to meet with me today, but more so that you were happy to, to kind of explore a few things that may have been really uncomfortable. So you handled that really well. I'm really pleased for that. And if I was in your shoes, I think I'd be feeling the same. So now you're making that empathy, making that connection with that individual. This is most of us. It's certainly me. This is me if I have to write an essay or an article. I get to about there and then just go, oh God, why doesn't that happen? Till the deadline comes through. Look, Rebecca's like, yeah, that is you entirely. I get it done eventually. They're just in that position the day before or the morning before. So most people struggle to maintain motivation. And that's why if you've elicited the importance, you've documented those kind of things, you know what to come back to when you see them the next time to familiarise them with why these changes are important, especially now they've already got these conditions. How can we minimise impact of these conditions on you now? A lot of patients with long-term conditions, comorbid conditions will say to you, what's the point of giving up smoking? I've already got COPD. What's the point? When we know that actually if you give up smoking, your longevity of life, your reduced impact of disease on your life is considerable. So it's still something that's really important for you to do. Yeah. But yeah, they might end up there. And that's what you all look like. That's that. Any questions?